Welcome, everyone, and thank you for joining us today. My name is Catherine Capps, and I'm the Executive Director and co-founder of the Get the Medications Right Institute. We know many of you are not satisfied with the management of your PBM, pharmacy, or medical benefit programs, and you are urging your PBMs and medical carriers to offer innovative ways to manage medications. Now, medications are essential, particularly in managing those with multiple chronic conditions. They're also important to the health of your employees. Today, we'll discuss new ways forward, allowing you to avoid the waste, create accountability, and ensure that the dollars you are spending are spent well, what we call a buy right strategy. If you consider that 80% of the way we treat and prevent illness is through medications, use of medications, getting the medications right is extremely important, and it should be the first order of business for those that you contract with to manage your pharmacy and medical benefits. Today, you'll hear from two experts, one a seasoned and experienced employer benefit strategist, the other a well-respected researcher and clinician. After their presentations, I'll facilitate a discussion with them, allowing for your questions and answers. We have a terrific presentation for you today, so sit back and hear how innovative benefit design can impact your bottom line. Before we get started, I'd like to thank our sponsor, AbbVie. I'd also like to thank the following individuals that contributed to the creation of our newly launched employer toolkit. Those individuals include Jessica Brooks, Pittsburgh Business Group on Health, Jerry Burrell, Purchasers Business Group on Health, Marianne Faison, Dallas-Fort Worth Business Group on Health, and Texas Business Group on Health, Gay Fortner, Healthcare 21 Business Coalition, Neil Goldfarb, Greater Philadelphia Business Coalition on Health, Cheryl Larson, Midwest Business Group on Health, Troy Ross, Mid-America Coalition on Healthcare, Chris Spearson, Healthcare Partners Nevada and Nevada Business Group on Health, Karen Van Cole, Florida Alliance for Healthcare Value, and Jane Cheshire Gilbert, Teachers Retirement System of Kentucky. The Institute truly appreciates their tireless dedication to getting medications right. I also want to draw your attention to some recent findings from the Institute. Recently, we conducted a survey on some of the biggest issues in healthcare and medication management. The results were truly eye-opening. When we asked healthcare leaders about the biggest issue in healthcare as a whole, the overwhelming answer, to no surprise, was cost. However, when we ask about the biggest issues in managing medications specifically, more people chose lack of communications between prescribers and pharmacists rather than cost. Let me repeat that. Respondents believe that problems due to lack of communication between physicians and pharmacists, who are vital members of the patient's healthcare team, was more of a problem than the cost of medications themselves. Now, we followed up these questions by asking what should be the first step in changing the current way we manage medications. Responses were almost evenly split between having physicians work in collaborative practice with pharmacists to help patients reach their clinical goals of therapy, to access to clinical information at the point of care for all team members working with the patient, to include the clinical pharmacist, and then finally, payment for comprehensive medication management services. And finally, another key finding was that 84% of our respondents believed that implementing CMM services could help stem the opioid crisis. That's 84%. So that's why we believe a more comprehensive, team-based approach to medication use through CMM in practice is needed today more than ever. Now, for those of you who are saying, well, this sounds great, but how does it work? We have a short little explainer video that'll give you the general basis of what CMM looks like for a typical patient. This should be good background for you for the rest of today's presentation.
Did you know nearly 75% of primary care visits involve prescribing medication? Modern science has made over 10,000 medications available on the market today. With so many choices, how can you be sure that a medication is right for you? Who do you turn to for answers? Nearly 30% of adults take 5 or more medications, and even though it has the power to heal, it can also cause harm. The older we get, the more medications we tend to take. We see specialists to treat long-term health issues. This means that the more doctors you see, the more medicines you take, which can lead to unfavorable side effects and medication disasters. Disasters occur when doses are too high, too low, when a medication isn't suited for your genetic makeup, or when taken in combination with other medications. Long story short, prescription medication disasters can make people sicker instead of better. People end up in the ER, hospital, or nursing homes and sometimes die. It's a terrible waste, but the good news is it's avoidable. Your doctor can order a service for you called Comprehensive Medication Management, or CMM, with a medication expert who can evaluate you and answer your medication questions. As a part of your doctor's team, you will meet with a clinical pharmacist to ensure your goals are met and all of your medications are safe, effective, and appropriate for you. After understanding your needs, reviewing your medical record, test results, and health history, the clinical pharmacist creates a plan for you with follow-up evaluations. It's like having a medication coach. Hard to believe? 95% of patients say CMM improved their health and well-being. Talk to your doctor about services designed to get your medications right.
That explainer video can be found on the website at GTMRx.org for those of you that are interested in that. So let's get started. Let me introduce our presenters today. We're going to start off with Sandra Morris, formerly a senior manager of U.S. benefits for Procter & Gamble. She'll explain the importance of comprehensive medication management through the lens of a benefit plans strategist, with benefits provided to employers, and explain why this should be important to employers and what they can do to make it happen. After Sandra's presentation, we'll hear from Dr. Jan Hirsch. Jan is the founding dean of the School of Pharmacy and Pharmaceutical Services at the University of California, Irvine. She'll review the evidence from 3 different perspectives, and she'll explain why CMM makes sense to those interested in optimizing medication use through CMM in practice. I'd also like to mention that Jan has been very involved in the work of the Institute. Not only is she a distinguished fellow, she's been very involved in the development with those individuals that I named previously in the development of the employer toolkit. So without further ado, I will turn it over to Sandra, and I suggest that those of you that are on the line that would like to submit questions, please submit questions while the presenters are going through their presentations, and I will facilitate a Q&A period at the conclusion of both presentations. With that, Sandra.
Thank you, Katie, and I'm glad everyone could join us today. Many of you are probably responsible for managing the healthcare plan of your employer, or if you're not, you're at least impacted by the items that drive the cost of your healthcare plan, because your employer has already long ago decided that you will share in a percentage of the total cost of healthcare for all employees of your company, and that percentage amount could be anywhere from 25 to 30%, and it's seen in the way of premiums and deductibles and copays and all of the things that you pay out of pocket with your healthcare plan. So obviously, when the costs go up, your costs go up. It is important for employers to take a look at what is going on within the current system of delivery of medications across the US. One of the things that we know is prescription drugs as a whole are only about 10% of US healthcare spending. But when you look at employers, it's more like 19% or higher, and that's even after rebates are calculated into that. So the employer plans tend to be quite lucrative when it comes to the employee being able to utilize medications at a lower cost to themselves. But someone is paying that bill, and actually it is the employer, and the employer is in turn putting a share of that cost back to the employee. So it's almost like a vicious circle that is a never-ending thing. And obviously the cost of prescription drugs in particular are increasing at a very rapid pace because of the types of changes that are occurring in the market today, with a lot of different drugs coming to market, and many of those, of course, being biologic drugs. When we look at private insurance, it covers about 40% of the national prescription drug cost. That surprises people. Medicare, most people think that Medicare would be the highest spender when it comes to medications, but in fact, it's only about 30% of the contribution to the spend. Employers in particular, one of the things that many may not realize when it comes to the prescription drug plan is it's no different than the medical plan. Employers have, by federal law, a fiduciary responsibility to act prudently and avoid the risk of healthcare plan losses. Losses meaning those things that are being paid for that are not effective, are not achieving the outcomes that you would expect to achieve for the payment of those services. And what we have today in reality is a trial and error system of medication use. Basically, you all have seen it. You've gone through it yourselves probably many times. You go to the physician with a health condition. Many times it's a chronic type of health condition that you know you're going to take medications over a period of time to treat. And the physician starts with a medication. It may be one that the physician has utilized for many of their patients in the past and they feel comfortable with. Because keep in mind, we're talking about over 10,000 different medications being available within our system. And obviously, physicians can't know about all of those medications and know how they're going to impact individualized patients. So they get comfortable with particular medications, and those are the ones they start with. And what they say is, I'll give you a 30-day prescription. Let's try this, and if it works, okay. If it doesn't work, we'll try a different one, and we'll go another 30 days, and another 30 days, and another 30 days. And when you look at conditions, particularly chronic care conditions, that are significantly impacting someone's life, say, for example, depression, you're looking at a patient who is in a bad situation when it comes to the total quality of their life and their relationships with their coworkers and their families. And they're spending months trying to find the medication that is going to work best for them. What is the sad part about that is part of precision medicine today is there are genomic tests that can be done that can identify very quickly the types of antidepressants that are going to work best in that particular individual. But those things have to be known, and that is not what our system is today. As an employer, you have the call to action because employers are the ones that are best positioned to lead optimized medication use as a standard of care for our future. You are the one paying the bill. You are the one that most of the people involved in this whole network of care are going to listen to when it comes to understanding what the customer needs to have within their system. The next slide. So what's the big deal here? You know, yes, I'm an employer. Yes, I'm paying for a health plan. I know there's a lot of things I'm paying for that I probably shouldn't be paying for. But so what's the big deal about medication? Well, the big deal is there are many dollars and many lives that are being wasted and lost because of non-optimized medication therapy. We're looking at 16% of the total US healthcare spend that is being, you might even say, totally wasted because the outcomes are not happening that we're looking for in our patients and in our employees, and we're just not achieving those types of things. Fixing the problem could save over 275,000 lives per year. Now, what is the big deal? $528 billion a year are being spent, and a lot of that is your employer money. Over 275,000 lives are being lost every year, and those lives belong to your employees and or their family members, which is impacting your bottom line as a business. So with that said, there are things that can be done with this. Next slide. As an employer, precision and quality are important parts of the delivery of your business. It's being measured in some point within your business plan measurements on an ongoing basis, monthly, yearly. You know the goals that are there. You know that the quality that you're delivering to your customers needs to be the highest possible quality, and it needs to be precise so that you're not wasting a lot of your customers' money or wasting a lot of your money in terms of the time being spent by your employees doing things that are not effective. When we look at medication problems, there are all types of medication problems, and the one that you are most often initiated into, if you will, by your pharmacy benefit managers and medical carriers is adherence. And you'll hear that the big problem is adherence. Well, adherence is a portion of the problem. It's about 15% of the total medication therapy wheel, if you will, of the types of issues that can come up. But inadequate therapy is a much bigger part of that. And what do we mean by inadequate therapy? We're talking about therapy that, for whatever reason, is not going to be effective for that individual and their genetic makeup, either because of their genetic makeup, their social situation, their cultural beliefs. There are so many things that will figure into that. But for whatever reason, 58% of the time, the medication therapy is not adequate. And to make that even worse, between 50 and 75% of patients don't take their medications as prescribed. Now, that is for a lot of reasons as well. And all of the things I've talked about within culture and finances and all of that will play into those particular issues as not taking them as prescribed. But think about the current system that your employees are up against. What happens when an employee receives a prescription from a physician? Well, first of all, I can assure you that very little, if any, time is being taken between that employee and that physician discussing a new prescription. What do? They go to a pharmacy, they have the prescription filled, a bag is handed to them, they're probably asked to sign a piece of paper, and then a technician looks at them and says, "Do you have any questions?" Well, no, because they wouldn't know what questions to ask to begin with. There is no interchange happening at that point of sale between the pharmacist and the patient. What is happening is you're being given a piece of paper within usually the container or the bag that is in microscopic font, and you're saying by signing that piece of paper that you've been given the education that you need about this medication, and that is what you've been given. The reality of it is what happens with that are the consequences of medication therapy problems, and that's what we have a breakout here. $528 billion was spent in 2016 alone on non-optimized medication therapy. And those dollars were being spent on hospitalizations, long-term care admissions, emergency department visits, provider visits, and of course, additional prescriptions. But more importantly, over 275,000 deaths occurred from that non-optimized therapy in 2016 as well. So we are looking at the average cost of an individual that experiences treatment failure or new medical problems after an initial prescription use. You're looking at well over $2,000 for each individual. And think about the number of individuals under your healthcare plan that are actually experiencing this. Next slide. So what's the proposed solution? Well, when we look at the rest of the world, even the medical world, say, for example, you go to a general practitioner and the practitioner believes that you need to be referred to a specialist that understands better how to treat a condition that has been identified by your primary care physician. And there's physicians out there that do nothing but spend their day every single day inside and out working with that particular condition. Makes perfect sense. We all go through that. We're proposing that we do the same thing when it comes to medication management. Let the people who have the best knowledge and experience in utilizing medications become the coach and the partners for the patients that we know need more attention on an everyday or every month basis. We know those people. We look at their healthcare records all the time when it comes to total costs. We can't identify them individually, but you can look at your healthcare costs and see individual cases where it's obvious that the patient is not achieving the clinical outcomes that should be there. And when you look at the medication spend of those patients, it's enormous. So we're looking at a lot worse situation in the future. The shortage of physicians is going to be up significantly in the future. And we are going to have to utilize services that are in the outfield, if you will, for help with the care of these patients when it comes to this type of situation with the shortage. Again, study has already revealed 26 seconds are spent by a physician on average in a little over 15-minute office visit. 26 seconds is spent on guideline recommended components and 23 seconds on all other aspects of prescriptions when talking to patients in a new medication. The patient, depending on their condition, needs varying amounts of added care. And the people that can provide that are there. It's the system that needs to change to be able to accept the specialist as those primary providers of care when it comes to medication therapy management and pay for those services. The savings themselves are well worth it in terms of putting this type of a care pattern in place. I'll give you an example of something that happened with me this week. I just moved recently, new to the area, and I ended up having to go to an urgent care center. I saw a physician, very nice man, seemed to be very competent, but what happened in this interaction, what has apparently happened is I had major foot surgery a few years back, and apparently one of the screws that was put in has dislodged itself in my foot. So I'm having extreme swelling and pain and all of that. So this physician, of course, refers me to an orthopedic surgeon, which I expected to happen. He also prescribed a medication. Not one word was said to me about that medication. I went to the pharmacy. I had it filled. No one asked me anything in terms of any background on any other medical conditions that I had. I, was basically given a bag with that piece of paper in it. Well, I couldn't read the font on that. I do have elderly eyes here, and I couldn't read the font. So I went to my computer and looked up the drug itself and looked at all the indications and all of that. There were numerous things that I needed to know about taking that medication, and none of those were reviewed with me. So how was I going to get the optimal outcomes that we were looking for on this medication with that type of interaction? Most people would not. Next slide. So you go back to it as an employer or as a member under a health plan. Well, wait a minute. We've got our medical plan carrier, we've got our pharmacy benefit manager, and we're paying them for things like prior authorization. How is that not utilizing the specialist? Well, it's not. PA, for example, is a one-time process. It's not conducted by a pharmacist. It involves completion of a list of questions to determine if one single medication is FDA indicated for the use in treating the condition, whether or not step therapy, meaning a different medication needs to be taken first before this med, and whether the drug is covered under the prescription plan for that particular member, and at what formulary level. That is prior authorization. Ask your PBM, for example, of a couple of examples of prior authorization checkoff sheets for some of the common drugs that your employees are using that require prior authorization. And what you will see will surprise you. Medication therapy management. You'll hear the term MTM. That is a Medicare Part D covered program that might be conducted by a pharmacist and usually involves the review and documentation of a drug list and a medication-related action plan. So they're looking at all the drugs they're on and they're doing a plan for how is it going to be managed in the future. Those two are what are being done primarily today. And that is what, if they're being provided, prior authorization probably is, medication therapy management, maybe not by your PBM with your active employees, but what is not being provided is comprehensive medication management. That is a much different process, and we're going to talk a little bit more in detail about that before I turn it over to Dr. Hirsch. Okay, next slide. So what are we looking at in terms of progression of clinical pharmacy intensity? What you're seeing on the left is what I experienced this week. Very low interaction, very little, if no, education, episodic care, and that can progress into a much more high quality, focused, patient-centric experience for the patients that should receive this type of care. And you'll get the optimized clinical outcomes from that. So let's look a little bit in more detail about comprehensive medication management and see how it would differ from what you currently see today. Next slide. When we look at a formal definition of comprehensive management, it is a systematic approach. It involves physicians and pharmacists working together to make sure that medications, whether they're prescription, non-prescription, alternative, traditional vitamins, or nutritional supplements, whatever is going into that person's body, are individually assessed to determine that each of them are appropriate for the patient, effective for the medical condition, and most importantly, safe given the comorbidities and the other medications that are being taken by the patient. Next slide. It's not a small process. It's involved. It's a 10-step process. It starts out by identifying the patients who are not achieving the clinical goals, understanding their the patient's personal medication experience, history, preferences, beliefs, all of those things that would impact that patient's ability to take a medication that is prescribed. Looking at the patterns of use of all of their medications, including everything that is going into their body from an OTC standpoint, from a bioactive supplements, from any other type of, quote, medicine that is being used by that patient. Assessing for the appropriateness and the effectiveness and the safety, including drug interactions and adherence. For focusing on that, identifying all of the drug therapy problems there, and making sure that it is documented very clearly to a team of experts who will then develop a care plan for that particular patient, work with the patient directly to make sure that the patient, number one, understands, and number two, agrees with that plan of care, documenting everything for all parties involved, following up the evaluations to make sure that the effects of changes, reassess the actual outcomes, further reassess the therapeutic changes that might be needed, listen to the patient and understand what they as an individual person are experiencing when it comes to taking this medication, and then starting that process all over again, making sure that it is a continuous process for the patient whenever anything changes about that patient's life. Next slide. So, benefits for CMM for employers and employees of employers for that matter. Number one, improved clinical outcomes. You've got a specialist for medications working directly with a team of medical carriers, including the patient and their physician, to make sure that all of those medications that person is taking are achieving the clinical outcomes they're intended to achieve. And if they're not, intervening and doing that quickly and efficiently with not a month or 2 months or more involved in trying new medications because you find out after a month of care that nothing's working for them. Decreased employee absenteeism, that's a no-brainer. If you've got an employee that is achieving the clinical outcomes of their medical care, they're going to be at work. They're going to be productive while they're at work. And that is a huge difference when it comes to the outcomes for your business. Reducing healthcare cost utilization. All of those costs you saw earlier, emergency department visits, hospitalizations, and readmissions, those are all proven in studies to be significantly reduced by the use of comprehensive medication management. A reduction in your total healthcare costs on an average of about $1,000 per participating member per year. So look at all the people just with chronic conditions that are out there that are taking numerous medications, all kinds of over-the-counter things that they've heard are good for their condition, and still sitting at the numbers in terms of clinical outcomes that we don't call effective in terms of treating the person themselves. They're not productive at work. They're not at work. Their relationships with their family members, their coworkers, et cetera, are significantly impacted by that. But more importantly, your financial group is going to say, why would I invest in doing something like this? Or why would I invest in having my medical carrier or PBM provide this service unless I'm going to get a return? So what's my return? Well, for your individual population of people, it's clearly going to depend on the number of people that you have that would clearly be identified as needing comprehensive medication management. But the studies that have been out there have proven that it's anywhere from 3-to-1 to 5-to-1 in the first year. So, and that is, of course, an ongoing thing with that. So with that, I'm going to stop and let Jan take over to explain where this is in action now and what some of the outcomes are.
Thank you, Sandra. Appreciate that. Next slide, please. So what I'm going to do is try to give you a little bit of a glimpse on like, how does this happen? You know, from the pharmacist perspective. The first thing I'm going to talk about quickly are some different models that have been utilized with employers. And then I'm going to show you some cases, real patients that have benefited from CMM. So first of all, I've got 3 different models here, and these are all published in the literature. And the first one is the employers and the health system pharmacist. Next slide. And I'm going to just summarize really briefly, what did this study find with this particular model? The health system pharmacist was working in a like a hospital pharmacy, but was also providing services to the employees. And they found that the percentage of patients that were at their diabetes goal increased from 66 to 75%, and they also had reduction in cholesterol. They estimated employer savings per patient, about $253 for medications and about $1,000 total cost on average. And the patient satisfaction was very high with the program. Next slide. The next study had a model of an employer, but they brought in a community pharmacist into the employer site. And they found again, this was focused on diabetes, which is very common. They had an improved percentage of patients at goal from 55% to 72%. And then they measured blood pressure and there was a reduced mean blood pressure. They also looked specifically at resource utilization and saw 30% lower hospitalizations and 24% lower ED visits. Next slide. And the last model that I've chosen to highlight here, because there are employers using different models with pharmacists, this one looked at diabetes again and saw that improvement in the percentage of people at goal. They started at 38%. That had improved to 62% within that year. And they also measured cholesterol and saw a mean reduction. Again, resource utilization was examined. Total medical costs decreased. Physician, hospital, emergency department visits all decreased. Labs decreased, but prescription drug costs increased. And that is what you'll see in most programs. You can expect to see maybe medication costs goes up, but it is these other costs, the subsequent medical costs, that are going down because it's improved healthcare, it's improved outcomes for the patient. And this study looked at patient behaviors. Sick days. 6 days actually reduced from a mean of 12 per year down to 6 per year. And the employer estimated that that was about an $18,000 per year value to them. Yeah. And then they also saw an increase in the number of self-care activities that the patients were doing that are very, very important in diabetes, specifically for preventing future health costs. Next slide. So now I'm going to change, those were models from a macro standpoint. I want to take you to 3 patients, and I'm going to walk you through what's happened very quickly in a CMM encounter. And I give thanks to my colleagues. I just reached out to them last week and said, can you send me some example cases? So these are cases that they've seen recently. It's all de-identified and it's all simplified also. So next slide. Okay, here's a case of a 55-year-old female. All right, this is diabetes. We have some labs available, and this is exactly from what the pharmacist is seeing and doing. This is the real patient. The lab values, there's an A1C. That's a lab value that measures glycemic control, and it's a 12.3. All you need to know is it should be less than 7. A fasting glucose level was 269. It really should be more like 70 to 130. Right? So this person is not controlled in diabetes. They're on 3 different medications. Of note, the first one is for their, it is an injectable, and it is prescribed for 42 units twice a day, but the patient is only taking it 40 units twice a day. Then there are 2 other oral medications. Looking at their vitals at the first visit, their blood pressure, heart rate, temperature is fine. They are overweight. And then the patient reported glucose. And this is where the patient is actually measuring their glucose. And they have one that's fasting average and one that's after their meal. But both of these are consistent with the A1C, the other lab values, and they're out of range, basically 165 when it should be 70 to 130. After a meal, 347, but it should be less than 180. So you can clearly see the diabetes is not controlled. Next slide. The medication changes. I'm not going to go through all of them in great detail, but this is what happened with this patient. With this glipizide was switched to another drug, Jardiance, at the first visit, which was in September. The patient was asked to use that full dose that they had already been prescribed, but they weren't using, of the injectable. And then the patient came back in November. After that was being in September, there was an increase in the dose of the Jardiance. They came back in March. Humalog, which is another injectable, was added. And then over the course of the next visits, there was an increase in their Levemir, and they increase it incrementally at different visits, as well as there's an increase in Humalog at different visits. And they're ending up on the right-hand side, that's their medication regimen. But important on the bottom here is the patient continues care with their primary care physician and also was referred and went to 2 visits with their dietitian. It's a team-based care. The pharmacist part of this is measuring and assessing and managing the medications, working within the team, but working with the patient as well. So what happened with this patient? Next slide. A1C, that's the main thing we're measuring. A1C went down, but you can see it went down over time. And by April of 2021, it was below 7, and that was our mark that we want to be under. The takeaway points from this case are the patient was referred, they were not at goal, and that's one of the CMM hallmarks. Prescribed does not mean that that's what they're actually utilizing. Even at the beginning, they weren't utilizing what had been prescribed. Consistent follow-up is needed to assess over time and also to make adjustments. And this is a very clear example of that. Multiple medications are needed oftentimes to control a single diagnosis. Changes are made over time. It's not something you do all at once. It's you change, assess, change, assess. And it is team-based care. It's not just the pharmacist, it's the pharmacist working with other professionals and the patient. Next slide. This is a 44-year-old male. He has diabetes, but he also has high blood pressure and high cholesterol. Available labs, we already talked about A1C. His is high, not quite as high as the other one, but it's above the 7. His LDL cholesterol is also high. We want that to be less than 100. He is on 4 different oral medications for these conditions. On the top right, his vitals, he has high blood pressure. We want to get that down, and he is overweight. But now in this case, there are patient-reported concerns. His concerns are excessive daily and nightly urination. It's affecting his work productivity and his sleep. He has recent erectile dysfunction. He's not checking his finger stick glucose. He's not monitoring his glucose like the prior patient was. And he's afraid of needles. All of these drugs over here are orals. They're not injectables like it was with the other patient. Next slide. So here's what happened, and there are multiple problems with this, but looking at the diabetes, the metformin was continued because it's highly efficacious and it doesn't have a weight effect. The linagliptin was discontinued. The patient did not want to start this other type of drug because it had a high urination side effect. So the patient was involved in making this decision. They started another drug instead, semaglutide, and titrated that over 4 weeks. That was started because it's high efficacy, but it also has a weight reduction advantage. And then really importantly, they started measuring the glucose, but not with a finger stick. The patient was given actually a sensor to use and an app so they could improve their adherence with checking their glucose levels. But also that allowed them, the pharmacist, to teach the patient the correlation between their food and exercise levels and their glucose values, which will go a long way in this patient's progression or lack of progression. So the poorly controlled blood pressure, they started a new drug there because, again, the patient preference did not want to start a diuretic. They continued on some other, that's lisinopril. But the patient was also advised, check your blood pressure daily and on a DASH diet, a low sodium diet. Poorly controlled cholesterol, they increased the dose of the atorvastatin. The erectile dysfunction that was expected to resolve with improved glycemic control with the diabetes, but if not, they would refer to a urologist. And then the obesity, that semaglutide that was started for diabetes was also going to help with the weight loss and counseling on healthy eating and exercise. Next slide. So what happened to this patient? Right? If you look up here on the left-hand side, it was the initial visit, 2 months and 4 months. So this is a 4-month period. The A1C dropped from 9.4 to 7. Blood pressure dropped as we wanted. LDL reduced, weight reduced, BMI reduced. The diabetes A1C is close to the goal of less than 7%. The blood pressure is at goal. The cholesterol is close, but the patient, again, the patient preference, did not want to increase that medication dose. He's continued to lose weight and the erectile dysfunction resolved as expected. Again, the patient continued their regular care with their primary care physician throughout this. Takeaway, the patient was not at multiple goals, and that's why he was referred for CMM. The patient was involved in the decision-making many different places. Again, that consistent follow-up was needed, and changes are made over time. Is not just one time and change, and that's it. And the last case, next slide, is a 62-year-old female with high blood pressure, depression, overactive bladder, and pain. There are 4 medications down the left, all oral, that she's taking. At the first visit with the pharmacist, her blood pressure is at goal, but she has a diagnosis of depression, overactive bladder, and pain diagnosis. Note there are no lab values for these. These are things you have to talk to the patient about their symptoms to understand whether they are controlled or not. Yeah. The patient's concerns were she had had some recent falls and daytime sleepiness and dizziness. Next slide. And just looking at the medications alone tells you that 3 out of the 4 medications can cause sleepiness and dizziness. Next slide. So through discussion with the patient, the pharmacist determined the depression was well controlled. The overactive bladder was well controlled, and the pain was described as mild. So at first visits, the overactive bladder medication was decreased to once per day. And then the tramadol, which was the pain medication, which is a synthetic opioid, was switched to an OTC medication, acetaminophen, for pain instead. And then 2 weeks later, they were able to discontinue the overactive bladder medication. So this is a good case of where discontinuing medications that symptoms have already been controlled, you don't always need to actually continue the medications. Next slide. So in the end, the medications at 2 weeks, and this is a much shorter period than the other 2, we were down to 2 prescription medications, 1 OTC. We discontinued 2 medications completely. The patient did continue to see their primary care physician, just as the others. Takeaway point says lots of times there's not labs. There are not labs you can look at on a piece of paper or an electronic health record. You need to speak with the patient, and that's what the pharmacist does within CMM. Takes the time to work with the patient, involves the patient in the decision making, because a lot of diseases are symptom reporting, and that's what you're judging success by. Follow-up is needed in this case to address the risk versus the benefit of a medication. The risk is these medications, 2 of them were making her sleepy and dizzy, and thus falls. Medications have risk, and oftentimes the benefit does not outweigh the risk, and that needs to be assessed along with the patient. Discontinuing medication is possible if you're working directly with the patient. Changes can occur quickly. This was a 2-week. And again, it is team-based care. It is not done in isolation, and that is a hallmark of CMM. Next slide, please. So you should be thinking, okay, who benefits the most? And I think Sandra touched on this a little bit here. This is actually an element within the toolkit Katie's getting ready to tell you about. But basically, the people that are going to benefit the most are those with at least 1 or more chronic medications, one or more chronic conditions. Maybe they're high utilizers of ER visits, hospitalizations, urgent care. They're not at goal is the point. And you can see that. You can see that in their patterns. Complex medications also, or things that you would like injections or inhalers, things that need a lot of education. And if the patient isn't utilizing it right, then it's not going to be effective, and it could be harmful. So another area I just want to point out is transitioning. Patients that are transitioning from an ER back home, hospitalization back home, even between physicians and different care settings. Things are changing, and the pharmacist and CMM can look at all those medication changes and help to rationalize that for the entire team on behalf of the patient and their benefits. Next slide. So from an employer standpoint, if you are implementing a CMM program, or if your PBM or your health plan is, what kinds of outcomes could you be assessing? And over on the right-hand side, these outcomes are clinical outcomes, just like we talked about. So I've already sort of talked about that. On the left-hand side, there are process care measures, and I only put a few here just for an example, like the process of the CMM. So an example could be the patients with greater than 1 chronic condition, or more than that if you wanted. how many of those are actually receiving CMM services at least twice annually, for example. And maybe you want that to be really high at 90%. Or patients with at least one chronic condition that have a CMM encounter at each one of those transitions of care. Or patients and medical providers actually grant access to the patient's EHR for the CMM team, a real process kinds of thing, because you have to have access to the data for that. So metrics are important. They're very important for measuring the outcomes to the patient, but also the quality of the program. And with that, I'm going to end and hand it back over to Katie, who's going to introduce this toolkit.
Thank you, Jan, and thank you, Sandra. So to help you with what we've discussed today, the Institute has created, and I mentioned before, who participated in the creation of that. Some of those individuals are on the call with us today, and already mentioned Jan Hirsch and Jonathan Watanabe. He's also on the line with us today. Were instrumental in kicking off our employer task force. We've spent over 12 months developing a toolkit that could be used as employers work with their PBMs, their medical carriers, their benefit consultants, and other solution providers like pharmacogenomics, diagnostics, those firms that offer companion and complementary diagnostics, as well as employees. We are developing some consumer tools in this employer toolkit. One of those you saw, which was the explainer video, you saw that earlier. And the key focus of the toolkit basically is, what is CMM? How does it work? What's the return on investment, or what should you expect as it relates to return on investment through your CMM program? What types of patients benefit most from CMM? And how does CMM work with value-based payment? And then how does it fit? How does pharmacogenomics testing fit in with delivery of CMM, or optimizing medication use through CMM in practice? In addition to the toolkit, we've also developed a resource center. Next slide, please. And you'll find in the resource center a number of other tools. In addition to the toolkit, frequently asked questions for employers, an infographic about drug spend, using pharmacogenomics and other diagnostics, contracting for CMM, and then a very important evidence document, which all of us need and want, particularly as we work with benefits consultants and actuaries, that outlines the claims that we've structured as it relates to CMM: better care, lower cost, higher provider satisfaction, higher patient satisfaction, and savings, total cost of care savings. So I encourage you to visit our website and download the toolkit. You should have gotten it as part of the registration today. Next slide, please. Before we go into the Q&A period, I want to take just another opportunity for those of you that joined us later to thank the individuals that you see on this slide for not only their support, but their participation with us as part of the employer task force and their leadership. You'll hear continued leadership from these folks. They're part of the employer task force of the Institute. So with that, I'm going to turn it over for questions and answers. Please, we've got a few minutes to ask a few questions. Please type your questions in for the presenters. But let me get started with just a couple of questions. Dan, can you help us understand the difference between what we call comprehensive medication management and traditional medication therapy management, or those of us that what we call MTM services?
Yeah, I think there's a lot of terminology problems in this, but the way I look at it is MTM is looking at it's a somewhat siloed, it's a one-off kind of intervention. And so the pharmacist is looking at a wide array of drugs, the patient's medications, and they're looking for an intervention that can be made at that particular time. They may or may not be working with the patient one-on-one. It could be some MTM is actually just from data records. Some MTM is the pharmacist is talking to the patient about their regimens, but the thing that there is not that continued follow-up that I've illustrated in those CMM cases. There's also, not importantly, there's not the collaborative practice with the physicians or other prescribers on that ongoing basis, and that iterative ongoing assess, change, working with the other health professionals, I think that's the key difference. So you can sort of think about MTM as a more of a one-time shot deal. CMM is more collaborative and is longer term. And it is focused, the other thing is it's focused on patient goals. Those goals that I had there, MTM may not have all of the data, like the lab data, et cetera, to know when the patient is at goal. And they might not be able to assess and change for the goals.
Okay, thanks. And Sandra, we have a question for you. I think one of the listeners recognizes that you have broad knowledge as it relates to benefit design and benefit strategy. But what do you think the general understanding of CMM is among human resources and benefit executives? And what should we do to ensure that there is a broader knowledge base there? Sandra, you're on mute.
At this time, the knowledge of those individuals is pretty low. This is why we are here today. This is why the toolkit has been created. And I believe that how we can impact that is to work with the coalitions and the employers in terms of the benefits conferences and items such as that, newsletters, those types of things, to be able to, in a simplified manner, explain what is CMM, why is it important to implement CMM from an employer and employee basis, and how do you get started? What's the conversation that needs to start with your PBMs and your medical carriers? Employers do not want to create the wheel. They want to ride in the buggy that the wheel propels. And they want the buggy to be sturdy with good wheels. And that the way that we get there is by first identifying to our carriers, what is it that we, as your customer, want to happen? How do we want the outcomes measured of that implementation? And how is that process going to be reevaluated on an ongoing basis to make sure that it is achieving the goals that we need it to achieve? And making sure that the payments first are there for the services provided and are covered under the plan, and not massively difficult to implement in terms of getting the services covered under the plan, communicated to providers, all of that it is a covered service. And then also, having the structure set up within the actual plan itself, if that's the easiest way to go, so that the PBM is directly providing those services. And that can be done in a lot of ways. I mean, there's colleges of pharmacy that, could very easily provide those services through a healthcare plan. But the need needs to be recognized and the need needs to be communicated that those are the types of things that we're looking for out there as employers. So learning process, and it needs to start with educating the employers exactly what is happening today. And, I can't tell you the countless number of times that I got messages from my CEO saying, we want to reduce the cost in all departments by this percentage of your budget. Tell us how you're going to do it. And, you can either tweak your benefit design and hope that by removing covered services or doing something of that nature, putting more barriers in the way, that you're not going to have as many claims. Or you can look at it from a different strategy and say, what am I paying for now that is wasted money? And impact that waste. And this is an area of huge waste for employers.
So with that, Jan, I'll ask you the question, and Sandra has so eloquently laid that out. And of course, in the toolkit, there are some questions that people should ask of their health plans or if their medical carriers and PBMs. But Jan, from your standpoint, what do I need to know? If I'm an employer, what do I need to know to talk to my healthcare carrier or medical carrier if I want to implement these programs? What are the three key things that I need to know?
Yeah, I think you have to know, one, you have to know it's similar to what Sandra said. You have to know what CMM is and how it's different. And I think hopefully this helps with that, but also the toolkit helps with that. The other thing is, I think you need to know something about your patients. You know, where do you think your problems are? And that's, you know that at a level, a macro level. And then I think the other thing you have to know is you have to know what to ask them. And what you have to ask them is, what are you doing? You know, what are the steps that you're doing? And show me some of those steps and how that works. I would ask them, how does it work? Yeah.
So we only have time for one more question. I'm going to ask Caroline to move to the next slide. These are some things that employers can do now to lead the change, but I want to close. I want to ask the closing question, and Jan, I'll have you respond to it first, and then Sandra, because unfortunately our time is limited, and you guys have done a terrific job giving us a great overview. I'm interested in offering CMM services to my employees. Where do I find these services, or where do I contract for these services? And are there vendors or service providers or partners that I can reach out to? Jan, if you would answer first, and then I'll pass it on to Sandra. So
I think there are some vendors that offer MTM. There are not so many vendors, and I actually have only seen one. I sort of looked into this that says they offer CMM. I don't know the vendor. I don't know about it. I haven't seen that, and maybe some others have. But I think it's coming, and that's the point. We're on the edge of this becoming the next wave there. So in the meantime, what I would do is, depending on the size of your employee population, that's going to determine what kind of model you want to set up. But if I was in a particular market, I would either, if I'm very spread out, I would be talking to my health plans and PBMs about this, as we've been talking about. If I was in a smaller employee base, I would actually be looking in my community. I would reach out. If you have a school of pharmacy, they can help coordinate this. Even if you don't have a school of pharmacy, there are local pharmacy associations everywhere, and they can help you identify people that can provide these services to your employees.
Thank you, Jan. Sandra?
Yeah, I agree with Jan on all of that. And obviously, one of the other areas to look at here is employers get what they want when they ask in numbers. And, my advice is to work with your local healthcare employer coalitions to say, is this a service that we want to, as a group, purchase from a vendor? And then, do the normal process for looking for the appropriate vendor that meets all of the criteria that we've identified for comprehensive medication management. Your PBM is a source. However, I've seen a question of, I'm working with PBMs now, and I don't see a lot of interest by the PBMs. Well, I'm not a PBM basher at all, but the reality of it is I very clearly understand the system of healthcare or prescription drug purchasing and what goes on between PBMs and manufacturers and those types of things. Look at it from this standpoint. A PBM, in order to provide comprehensive medication management, is going to have to focus on the patient as an individual. This is not population health management. This is patient health management. It's an individualized process. Some of these patients are going to require changes in their medication therapy that might not fit the mold of the PBM's administrative process at this point. In other words, maybe through pharmacogenomic testing or through the one-on-one assessment of the patient with the clinical pharmacist and the other team members, it is discovered that for whatever reason, that perfect drug that is preferred on the formulary is not appropriate for that patient. And what's going to happen is that PBM is then going to have to agree to cover that drug in the same manner that they would cover a preferred drug, because it has clearly been indicated that this is the right medication the first time for that patient. And it's a matter of changing the goals here. The goal is not to see how much money can be made off of a rebate program. The goal here is to achieve the best clinical outcomes individually for the patients who are most in need of this particular service. So changes will have to occur in the paradigm of the PBM between the employer and the PBM, and how the process actually works with comprehensive medication management. And to do that, the employer is the one that is going to have to clearly say, this is what I am asking for as your customer, and this is how the process works. And go by the platform of comprehensive medication management and show me the plan for implementing a very good and precise comprehensive medication management program for the right individuals being covered under my plan.
So thank you, Jan. And thank you, Sandra. With that, today's presentation is over. I would encourage you to look for a follow-up issue brief that will cover that. We had some terrific questions that we were not able to get to. We'll try to cover some of your questions in that issue brief. And a copy of the recording of this webinar will be available from the GTMRx website within a week. To stay up to date about GTMRx activities and other learning opportunities like this, make sure that you follow us on Facebook, LinkedIn, and Twitter. And also visit the GTMRx website for our weekly updates and news briefs. Thank you so much for joining us today. Thank you, Sandra Morris and Dr. Jan Hirsch, for your informative presentations. Until we see you again, be well.